I'm happy to answer any emails or any questions via email. My email can be found on the slide. In addition, I'm only one individual as part of a larger team that's focused on building palliative care capacity and research and advocacy efforts around the world. And so to get more information about resources that we have available, invitations to participate in various palliative care initiatives like training programs or research, please scan the QR code and fill out this information and you'll receive regular emails from us. Again, thank you so much. I'm very honored to have been invited and I hope you have a very fun day learning.
Or another modality treatment, patient going to palliative care. So if our audience have question, discussion about palliative care or experience about palliative care in our hospital, can hand up your hand, audience or comment about the palliative care until we wait for Professor Akasit.
Good afternoon.
Especially
Can
for
you hear me?
pediatric oncology, Dr. Dian have. Dr. Dian, no? In Zoom, Dr. Dian? Okay. 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 Next, we have a second presenter, Honorable Professor Ekasit Travavichitkul, MD from Chiang Mai University, Thailand. Welcome, Professor Ekasit, in our hospital. This is curriculum vitae Professor Ekasit Travavichitkul, MD. Education, medical residency at Faculty of Medicine, Chiang Mai University. Diabot of Therapeutic Radiology and Oncology at 2004. Nora Medical University from March, June 26. Fellowship training and University Skillberg Hospital Campus School, Kiel, German. Work experience, of course, the structure of Department of Radiology, Faculty of Medicine, Chiang Mai University. Assistant Dean of Faculty of Medicine, Chiang Mai University. Assistant Dean in Faculty of Medicine, Chiang Mai University. Field, Radiation Oncology, especially brachytherapy, gynecology, cancer. Thank you for the Professor Ekasit. Now,
you're welcome.
Time for you. Please, Ekasit.
Yes. Okay. Good afternoon, everyone. During this period, at first, I wish to thank you for the Hospital of Mohammed Hossein to invite me to be the speaker in this session. Let me share my slide. Okay. Can you see my slide now? Excuse me, can you see my slide?
Yes, yes, you can see the slide. Okay.
Okay.
Yeah, you must show the proper PowerPoint. You can show.
Okay. So now I will start my talk. My talk will be about the CT-based brachytherapy for cervical cancer. So I just share some word like how far can we go. That's I want to share some developments of CT based on brachytherapy, and also other things that CT can do nowadays and maybe in the future. For the brachytherapy for cervical cancer, we have to accept that MRI guided brachytherapy is the standard in the world now, according to the many publications from international studies, especially the EMBRACE-1 study that published around 4 years ago that showed the benefit of MRI-guided brachytherapy. And for the CT, so this one is the option for the treatment because we accept that the MRI is according to the cost, according to the facility, I mean infrastructure to install MRI may be not possible. Let me share a little bit for the situation of CA cervix. This table I quote from the Global Can 2022 and share some data for in Thailand. For the whole world, the data of cervical cancer, we found around 660,000 patients per year. And for in Thailand, we found 8,600 patients. The thing that I want to show that we have a data from the Thai Astro database. We have around 4,574 of cervical cancer who receive a radiation therapy. From this data, we can interpret a little bit roughly that the first thing, around half of a patient have received radiotherapy in many settings. And for the mortality rate, nearly the same. It's around 50%. So I thought in Indonesia should be the same for the radiotherapy utilization. From the data, as the ESGO guideline, the treatment of locally advanced cervical cancer, the trend now they accept that the combination of external beam and plus image guided brachytherapy and in combination of chemotherapy is the standard of choice. I mean, for the standard treatment now. And this one is come from Europe. And I think from USA, in our region, nearly the same. So now we accept the using of the image-guided brachytherapy for the treatment. And normally we talk about the volume-based. Volume-based means we evaluate the dose to the volume of high-risk clinical target volume for the dose to intermediate risk clinical target volume, and also to the normal tissue such as bladder, rectum, sigmoid colon, and small bowel that close to the target. And nowadays, according to this data, we accept that brachytherapy for BOOST is still to be a standard treatment for locally advanced cervical cancer or inoperable cervical cancer who need external beam plus brachytherapy. This publication was published last year. This is a second version. The first version was published in 2019. They collect the data from the National Database of United States of America, and this show brachytherapy for BOOST. It have a better overall survival than without brachytherapy. And 10 years later, they collect the data again, and the study show the same result that for the BOOST treatment after whole pelvic radiation to treat by brachytherapy, BOOST is the same, better than no brachytherapy. So that's why we can say that brachytherapy for BOOST is this in the standard of treatment for the treatment in locally advanced cervical cancer. And normally when we talk about image-guided brachytherapy, yeah, as I said before, we talk about we talk about the MRI and CT-based brachytherapy. Let me go to the MRI first because this is the starter of the image-guided brachytherapy. This is the first publication of a clinical outcome of MRI-guided brachytherapy published by Professor Richard Potter and the team from Medical University of Vienna. Normally, they start the concept of MRI-guided brachytherapy. They have started since 2000. And in 2005, they published the first volume-based identification. And in 2006, they published the data about the dose constraint. And in 2007, they published the first results of the clinical impact in the MRI-guided brachytherapy. And after that, the using of image-guided brachytherapy in volume-based developed in our practice. In the center who have MRI, they perform MRI for brachytherapy in all fraction, in 2 fraction, in 1 fraction, or maybe pre-brachytherapy MRI to guide. And also in some center, they cannot approach MRI. They can perform the CT-based brachytherapy. And these 2 publications, this from the team from J. Castro, the Brachytherapy Society from Europe, they report the volume definition and also for the dose constraint. This is the first 2 publications that are published in 2005 and 2006 respectively. At that time, we know about high-risk CTV and IR and intermediate risk CTV. We call HRCTV and IRCTV together. And for the next step, when we talk about the CT, maybe you have a question, and how about the CT concurring guideline? Because at that time, this publication is from MRI. I can show you the publication of a CT guided contouring. The first CT guided contouring was published in 2007. That's for the collaboration between USA and Europe because in this publication, the first author is Dr. Akila Viswanathan. She's a work in the USA and joined with the team from Vienna. And at this publication, they contour in a CT and compare to the MRI. And for in this publication, they have the appendix that they have the guideline to contouring by CT. So we in Chiang Mai, in my faculty, we started the project of image-guided brachytherapy in 2008. So we use this publication, the appendix of CT guide contouring to contour our case at that time. And this version have like an update in 2014 in the Red Journal. They use the fusion of a CT and MRI at brachytherapy together. It makes this protocol. The second publication of CT-based brachytherapy contouring guideline from Japan, J-ASTRO from Professor Tatsuya Ono. He used a pre-brachytherapy MRI to guide for the contouring. But for the major concept, nearly the same as J. Castro recommendation. And for the publication from Dr. Viswanathan is the same from her publication. And for the latest publication, this from Professor Umesh Mahanchetty from the J. Castro and the Embrace team. They combine between IBS from the India, J. Castro from Europe, and ABS from USA, and make the guideline together. And from this guideline, they make the scenario that relate to the response. And normally, they make the scenario that we have CT for brachytherapy. For the ideal scenario of MRI guided, we talk to MRI at diagnosis. MRI pre-brachytherapy, MRI at brachytherapy, MRI at follow-up. But for the CT at brachytherapy, they divided to be 4 scenarios. The first, we have MRI at diagnosis, MRI pre-brachytherapy. In the second scenario, we have MRI at diagnosis. The third scenario, we have MRI at pre-brachytherapy. And the last scenario, we don't have MRI. We follow by CT. Maybe I will show the fourth scenario that we have only CT. And when we have only CT, normally this guideline suggests to use transrectal ultrasound to measure the volume we call NMD is near maximum distance, and also this one, and add some margin around that. And so the patient's cervix dimension will be measured by transrectal ultrasound, and we draw contouring to guide with them and add a little bit additional margin, and also for the superior to cover the things that CT have the loss benefit, because in the past there are the comparison between CT and MRI. The CT normally have an overestimation in radial dimension, I mean anterior, posterior, right and left. But for the height, I mean lower uterine segment invasion, MRI is better. So for the CT controlling purely only, we use lower 2/3 of uterocervical dimension. And also for vaginal margin, this guideline suggests to add a little bit margin around that. This one is the target contouring of the CT to CT environment, that you can see that we cover the lower uterine segment like a lower 2/3 of the margin. And according to the combination of the external beam and brachytherapy, we get the dose constraint like a panning aim of the treatment. For example, for high-risk CTV, we have at least 85 gray in EQD2. And for intermediate risk CTV, we need at least 60 gray. And for bladder, rectum, sigmoid, and bowel, from the ICIU 89 and the EMBRACE2 study protocol, they have a dose limitation to each normal tissue. And normally from the Europe and in the USA are nearly the same in the results of this one. Let me show some the results of the image-guided brachytherapy. On the right side, this from the EMBRACE1 study published by Professor Potter. And for the next is the from Dr. Alina Sousa from Vienna. She published the Retro EMBRACE study. And also from multi-center study from Japan from Dr. Naoya Murakami, Professor Naoya Murakami, and also from in the mid on the left is from my faculty. So this shows the results of the local control and overall survival. So you see that for the most of the publication, the EMBRACE1 is the highest result, is the show the 5-year overall survival rate was 74%. From our publication in Faculty of Medicine, Chiang Mai University, we can get around 69% at 4-year survival rate. And for the our study is close to the study from Dr. Alina Sousa from Retro EMBRACE study. Let me share some data from the EMBRACE1 study. Maybe a little bit thing that I can mention about this 4 study is the ratio of the hybrid approach. For example, in the EMBRACE1 study, the incidence, the using of the hybrid brachytherapy around 40% as the multi-center. And in my center, the hybrid technique, at that time we use 10%, but now we use more than 20% now. And also for the Retro EMBRACE study, they use around 20%. And for the EMBRACE1 study, they show the results at around for the local control 92, and for overall survival 74, and for the toxicity for the grade 3 and 4 study for the GI, they report around 12%, 11%, and for GU toxicity, they report around 8%. This is for the report of the EMBRACE-1 study, and also they report the local recurrence parameter, and they report some parameter from the dose, from the involvement, and also they report some special patient that we found the low residual disease at 3 months, and when we follow more than 9 months, we found complete response. This is some point that maybe change the guideline of follow-up in the future, but now we still evaluate the response at 3 months. Let me show the publication from my faculty in the Faculty of Medicine, Chiang Mai University. This parameter show, I will focus a little bit. For example, in the cumulative dose to the target in EQD2, we found that the dose more than 84 gray show better local control. That's why in our practice now we increase the cumulative dose to be more than 85. And also for the in this study, we collect the data from CT and transabdominal ultrasound. Although the result may be not different, but if you look in the overall survival and local control, our overall survival at 4 years show 73%. It's quite a little bit higher than transabdominal ultrasound a little bit. And another study in Thailand from Sirat Hospital, they report the using of image-guided brachytherapy in many approach, like a CT-guided, MRI pre-brachy, MRI more at least one fraction, and MRI every fraction. And if you look in the details, the results or clinical outcome in local control are nearly the same between CT and MRI. This may be support that the results of the MRI and CT are very close. And another additional prop, like to improve the treatment by brachytherapy was reported by Professor Murakami and his team. They report the using of the spacer to make the space between cervix and rectum, cervix and bladder, and show that the spacer can spare organ at-risk dose and increase high-risk CTV dose. However, the learning curve of the spacer injection in gynae, because normally spacer will be were used in the prostate cancer, and the cost of the commercial spacer is the point that we have to concern. And the next, I talk to the station of the brachytherapy. Normally, we talk to the nurse station, theater, imaging, loading room, and recovery room. But okay, it depends on your station or facility that we have. For example, in my faculty in Chiang Mai, we have the theater and we have the imaging and loading room in the same room. So we can less movement of the patient, no transfer between imaging room and loading room. So it depends on your facility that you can adjust to your practice. And maybe for the future, we can make the one-stop service. I know from this one, Elekta has just launched the Elekta Studio. This platform include the cone beam CT, like an O-ring X-ray, and remote afterloading and planning in the theater. Now they have a launch in some center in Europe and USA. So maybe in the future, in the center that have the only one operation room, this platform may be suitable to your practice. My conclusion is brachytherapy is one of the major components in successful treatment of locally advanced cervical cancer. Nowadays, from JGESTO recommendation to EMBRACE-1 study, image-guided brachytherapy is established to be standard image for brachytherapy in cervical cancer. and CT is an alternative choice to organ at-risk sparing. According to the impressive results of EMBRACE-1 study with 74% of overall survival rate in locally advanced cervical cancer, CT-based brachytherapy in retrospective study show very close clinical outcome. Maybe we are looking for the randomized or maybe bigger study to check the result. And with the benefit of the CT, we can put the CT in many stages, in theater or in loading room. So that's why, for example, just like an Elekta Studio that one-stop service can be performed, we can establish the ideal brachytherapy suite in many radiation oncology centers. I will end up my slide here. Thank you very much for your attention, and thank you, my team in MedCMU. Thank you.
Okay, thank you, Professor Ekasit, for that insightful presentation. Now we continue to session question and answer. We have in room and also in webinar. Okay, in Zoom. Like when Professor Ekasit in the chat question, in the chat Q&A, you have a question first from Agus Trijoko Suseno. And this question, what are the limitations of using CT imaging alone for defining the high dose region in cervical cancer brachytherapy? And how can MRI fusion or other advanced imaging modality overcome these challenges? This is a question from Dr. Agus, Professor. You can hear, or you can open the chat. A question and A.
Okay. I will check for the question. Sorry.
Q&A from Agus Trijoko.
Okay, let me the first question is, what are the limitations of using CT imaging alone for defining a high dose region in cervical cancer? Okay, for this case, the limitation of CT imaging alone, we have to accept that we cannot see the real GTV of the tumor and cervix, for example, when we perform the check the image. So the things that we can use to support the using of to identify the real tumor, I mean, if I understand the high dose region, that means the GTV, the first thing maybe we can use a pre-brachytherapy MRI. This is one option. And the second things with our standard of practice is a per vaginal examination. We can use both of them to identify the first thing, the tumor, residual tumor on the cervix. For example, an invaginal fornix or vaginal extension. And for the pre-brachytherapy MRI, we can use to guide for the GTV, the gross tumor volume. And the next thing, how can MRI fusion or other advanced imaging? MRI fusion you can use, but when we talk about pre-brachytherapy MRI, we have to think about the position, because when we apply applicator, the position of uterus change according to the applicator. So for this point, maybe there are some solution, because if we use pre-brachy MRI alone and when uterus change position, maybe it's not good to fusion. There are some practice, they use a Smith sleeve and put Smith sleeve before pre-brachy MRI. And with this solution, maybe we can feel better. And for the second question, how do the difference in dose distribution and normal tissue toxicity between 3D planning CT-based and 2D planning methods impact the long-term survival and quality of life of cervical cancer patients? How can advanced dosimetric parameters such as D90, V100 and EQD to be optimized during CT-based brachytherapy for cervical cancer to balance tumor control with minimizing toxicity to surrounding tissue. Maybe for this point, I can answer the second question first, because for the volume base, according to many study on previously, for example, some study from Canada and some study that show that with the image-guided brachytherapy by volume base, we can adjust the dose to the tumor to be a matching, for example, at least 80, at least 85, while sparing from the dose to normal tissue, because normally, for example, in my research, we set the research with the MRI at brachytherapy to about 10 years ago, and we found that with the response of the tumor in our practice, mostly 80% show the very good response, while around 20% show very bad response. Like the new publication from Professor Umesh, they declare to be the 4 type of the response as ICIU 89. So at this point, that means sometimes when we treat by conventional, the problem, I mean point A, the conventional point A, it can cause overtreat and undertreat, and mostly of our practice is the overtreatment. So that's why with the CT-based brachytherapy or maybe MRI guided, we can keep the adequate dose to the target. So normally we talk about 85, and by keeping like a sparing some the dose to normal toxicity, like a bladder, rectum, and sigmoid colon. This is for the second question of you. And for the first question, the difference in dose distribution and normal tissue toxicity between 3D panning and 2D panning methods impact the long-term survival and quality of life of cervical cancer patients. Okay, this point is quite interesting, because for the 2D and 3D panning, we have to think about the cumulative dose too, because for the 2D panning, if you say in point A, normally we talk about 7 grade 4 times, or maybe that it depends on the cumulative dose at each center. And also normally for the long-term survival outcome, in our internal analysis, because we have some experience to check and review the toxicity and some of our data, we found that for the 3D brachytherapy, we get a little bit survival advantage, especially in the stage 3B, like a more locally advanced. Because as I say to you that for the point A prescription, for the very big tumor at brachytherapy, sometimes it's under treatment. So for this group, image-guided brachytherapy, so in our subgroup, in some of our subgroup show a better in overall survival. And for the normal tissue toxicity, we used to collect the data around 10 years period, and collect the data when the patients come to admit to treat the serious toxicity. And yeah, this data is pending to report. Now we are writing the manuscript. And from this data, from our finding, we found that the 2D brachytherapy cause a higher serious toxicity, especially a fistula in our, but it is just only our patient in our center that we collect 10 years back. So maybe it's just some example. I think in the future, the comparison between, I think maybe CT and MRI, I'm not sure. And also for the 2D, because now, as I say to you that now image-guided brachytherapy that can improve the dose to the target and normal tissue. And most of the 2D, 80% are mostly we over treatment. So the thing of toxicity may be a little bit concerned. So I'm not sure for the randomized study in the future. Yeah, this is my answer. I expect that it may help.
Thank you very much, Professor Ekasit. Now in our audience in the room have Dr. Wahyudi want to make question. Please, Dr. Wahyudi.
Okay, thank you. My name is Wahyudi. I have learned to you in Chiang Mai Hospital for studying Brahi.
Good to see you again.
My question is, you mentioned before that you using spacer to reduce dose in normal tissue. Can you tell more about spacer you use in Chiang Mai or in Thailand to reduce normal tissue? What about the matter or maybe kind of shape of the spacer? And the number two, if we have a case, women with a cervical cancer, she has already get chemoradiation complete, and in some about 9 months after therapy, we have a pap smear result. The result is positive residual cancer. We have doing MRI, and the result is only local tumor. So we would to doing brachytherapy again. My question is, what dose we can give to her, or maybe we have experience to do brahi after the complete therapy. The vagina is rigid and we get maybe some difficult to insert the applicator. So do you can share your experience to doing insert applicator for this case? Thank you, Prof.
Okay, thank you very much for your very good questions. I will go to the first questions about the spacer. I have to accept that spacer has just come in Thailand last year. So in November, maybe just only 1 year in Thailand. And normally a spacer was used mostly in prostate cancer to reduce the rectum. Nowadays, there are some researchers, as I show you, Professor Naoya Murakami. He's a pioneer of to use a spacer in brachytherapy. So maybe you know him, and he has many more experience than me. Because for us in Thailand, yes, this is a very interesting because for the spacer, it can reduce dose to the rectum and bladder, and normally we can talk about the rectum, but the using of the spacer normally they use in the transvaginal to put the spacer between cervix and the rectum, and we need the procedure is nearly the same as when you inject in the prostate cancer. And from the publication from Dr. Murakami, he showed very promising results to reduce the dose to the rectum. However, the point of the spacer in Thailand, but we accept it in Thailand, is the very new, and also the cost of the commercial spacer is quite high. In Thailand, it's around 1,000, 1,100 Thai baht per 1 dose. So it's quite high. So it is very and also the experience of to inject the spacer, we need to train. Yes. So that's why for my experience, I accept that I have no experience about the spacer for cervical cancer brachytherapy, but I have some experience in prostate cancer radiotherapy that can reduce the high dose region in the when we treat. So because for the prostate cancer, no argument about the spacer. We use it for reduce the dose to rectum, especially for the SBRT for prostate cancer. So in my opinion, in principle, for brachytherapy that we give the as high as the SBRT, maybe more than SBRT. So we can use a spacer to treat to reduce the normal tissue dose, especially rectum too. But okay, for the material for the spacer, we have to think not only the commercial spacer. You can use the hyaluronic acid, high molecular, that the orthopedics use in the knee joint that they can use, and also for the autologous blood they can use. This is the first question. And for the second question about the local recurrence of cervical cancer, interesting point, we have to accept that for local recurrence, normally in that case, we talk about reirradiation, and the patient should, because normally for the first option in this situation is the pelvic exenteration or salvage surgery. So that's why when the patients come to consult, radiotherapy again for reirradiation. So that means the patient have no choice of surgery. Maybe for her risk or for her condition is not suitable, or she reject the surgery. This is a very good question about the dose. We used to some case like this previously, and normally in my practice, okay, normally we accept that maybe after 6 months of radical radiation, I mean for the first course, we possible to add the radiotherapy to her. But the thing that we have to concern is the how about the volume of the tumor? If her tumor confined to the cervix and central, it may be possible. And normally the dose that I use, and okay, I ask some specialists, for example, maybe Professor Christine Heidemeder from Institute of Gustave Roussy in France. Yeah, I have asked her about the dose schedule to her too, and she suggests me if you have high dose rate, and maybe the safety regimen maybe 5K 5 times, and maybe that can be used. But before you go to that, you have to review your previous dose. I mean the dose to high-risk CTV, the dose to bladder D2CC, the dose to rectum, the dose to sigmoid, and dose to your other normal tissue first. About the how high of them is low or high. If you high, for example, it's maybe to be beware. But if very low, for example, if you look at the EMBRACE2 study, the hard constraint is 70 to 75, and the soft constraint is 65. If your rectum D2CC is much more lower than 65, so maybe you have room to give a reirradiation, so you can get the same idea to other normal tissue. And when you review to your dose, thoroughly to your dose to target, dose to normal tissue, or in bladder, rectum, sigmoid, or other, and you find the gap to add brachytherapy. Yeah, I can support you. This is you have the choice to brachytherapy to her. Thank you.
Thank you very much, Professor Ekasit. I think we lack of time. Thank you very much to join with our webinar from Howard Hospital, Professor Ekasit. So finally, we have reached to the end of the presentation. Well, our session webinar for today. I would like to say thank you to all presenters for great presentation, especially from Ekasit Teraficule MD. And also for audience for their active participation. Hopefully the presentation will give a benefit for us, especially for our hospital, and especially for our radiology oncologists in our hospital. Thank you for your attention. See you later and have a great day. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh. Give a big applause for Dr. Rizal Sanif, SPOGS and Specialist Oncology, Mars PhD. And also we would like to say thank you so much for the chance from Professor Dr. Ekasit Teraficule MD from Thailand, and also Martha Salek MD from St. Jude, USA. Thank you so much.
Okay. While we are still waiting for our vice minister to join us, we'll be continue to our next session. Maybe this session probably we could have this in Indonesia. Baik, jadi sesi berikutnya adalah materi yang kedua yang akan dimoderatori oleh guru kita, Dr. Norman Jamaluddin, SPPD KHOM Finasim. Dr. Norman Jamaluddin lulus dari Universitas Sriwijaya dan saat ini menjadi staf di Rumah Sakit Muhammad Husin Palembang dan merupakan guru dari bidang hematologi onkologi di penyakit dalam. Kepada Dr. Norman kami persilahkan.
Baik, terima kasih kepada panitia. Assalamualaikum warahmatullahi wabarakatuh.
Waalaikumsalam warahmatullahi wabarakatuh.
Terima kasih kepada seluruh audien kita, baik yang di dalam ruangan ini maupun yang di Zoom ya, atas tetap hadir dalam acara kita pada siang hari ini. Pada sesi kedua ini kita punya 3 topik yang akan disampaikan oleh 3 expert kita. Saya kira ini sangat penting ya, mohon kita bisa mengikuti dengan seksama. Yang pertama adalah mengenai bagaimana mendeteksi kanker serviks dengan metode AI ya. Ini saya sampaikan kepada kita semua ya, bahwa metode ini memang dikembangkan di Palembang gitu. Jadi ini kalau nanti sukses nanti bisa dijalankan di Indonesia ya, Dr. Patius ya. Amin ya. Akan disampaikan oleh Dr. Patius, SPOG, subspesialis onkologi MAS. Judulnya adalah Cervical Cancer Detection Method. Oke. Mohon maaf Bapak-bapak, Ibu-ibu, karena ada sesi dari Wamenkes, barangkali kita tunda sebentar ya. Kami kembalikan kepada panitia, silakan.
Baik, terima kasih Dr. Norman for the time. Bapak Ibu hadirin sekalian, telah bergabung bersama kita Direktur Rumah Sakit Umum Pusat Dr. Muhammad Hussein, Ibu Dr. Siti Halimah SPKJ Mars, dan tentunya bersama dengan Wakil Menteri Kesehatan kita kepada Ibu Dr. Siti Halimah, kami persilahkan Ibu.
Ya, terima kasih. Assalamualaikum warahmatullahi wabarakatuh. Izin Pak Wamen, selamat sore Bapak. Apakah Bapak sudah bergabung Pak?
Mohon berkenan kepada perwakilan dari RS Paru Dr. N. Gunawan Parto Wikido.
Kita sebentar menunggu Pak Wamen ya Bapak Ibu sekalian.
RSP Dr. Sarjito. Mohon berkenan kepada Bapak Ibu.
Izin Pak Wamen, apakah Bapak sudah bergabung Pak? Kita sebentar menunggu Pak Wamen ya Bapak Ibu sekalian. Kita tunggu sebentar Pak Wamen masuk ya. Oke, baik, karena Pak Wamen masih rapat, mungkin untuk menyikat waktu, mungkin bisa Dokter Patius ya maju dulu. Tapi mohon izin nanti kalau Pak Wamen bergabung, kita cut sebentar untuk Pak Wamen ya Bapak Ibu, karena Pak Wamen waktunya sangat terbatas. Silakan dilanjutkan dulu. Nanti kalau Pak Wamen sudah bergabung, kita akan berpindah ke Pak Wamen. Terima kasih. Saya kembalikan ke pembawa acara.
Baik. Terima kasih banyak Dokter Siti Halimah. Kepada Dokter Norman, kami persilakan sebagai moderator dari sesi kali ini.
Baik, kembali ke laptop kita ya. Dokter, mana kurikulum vitae Dokter Patius? Baik, saya kira kita semua sudah kenal dengan Dokter Patius ya. Oke. Jadi ini Dokter Patius Agustiansa, SPOG, subspesialis onkologi Mars ya. Pendidikan dokter umum tahun 97, Magister Administrasi Rumah Sakit di UI 2017, konsultan onkologi ginekologi 2013 ya, dan doktoral sains medik tahun 2023 ya. Pengalaman kerja di Puskesmas Air Beliti tahun 97 sampai 2000, dan sekarang staf medis di divisi onkologi obstetrik ginekologi Rumah Sakit Muhammad Husin Palembang. Organisasi mulai dari ID, ketua di Musirawas, anggota ID lah, POGI dan HOGI. HOGI itu apa Dokter Hatius? Oh gitu, onkologi ginekologi. Baik, kami persilakan Dokter Patius untuk menyampaikan presentasinya pada siang hari ini. Silakan Dokter Patius. Sini aja.
Terima kasih kepada Dr. Norman atas kesempatan yang diberikan. Saya duduk sini. Ya, sini. Juga saya ucapkan terima kasih yang sebesar-besarnya kepada Rumah Sakit Muhammad Husin Palembang yang telah memberikan kesempatan kepada saya sebagai speaker pada acara webinar pada sore hari ini. Sesuai dengan tema kita dalam rangka memperingati ulang tahun Rumah Sakit Muhammad Husin yang ke-68, Transformation to Beyond Expectation ya. Jadi baru-baru ini kita kedatangan Pak Menteri Kesehatan. Pak Menteri Kesehatan juga kaget dan bangga atas transformasi yang telah dilakukan oleh Rumah Sakit Muhammad Husin Palembang, beyond expectation ya. Jadi memang benar-benar di luar dugaan atas kemajuan, capaian-capaian yang sudah dicapai oleh Rumah Sakit Muhammad Husin Palembang. Pada siang hari ini izinkan saya untuk menyampaikan salah satu hasil penelitian dan inovasi Rumah Sakit Muhammad Husin Palembang. Dalam hal ini kita bekerja sama dengan Fakultas Kedokteran Universitas Sriwijaya dan Fakultas Ilmu Komputer, di mana kita melakukan penelitian dan menggunakan aplikasi Teleotiva yang berbasis artificial intelligence untuk mendeteksi dini kanker serviks dengan menggunakan telepon genggam yang berbasis Android. Jadi sebagai pendahuluan bahwa kanker serviks masih merupakan beban dunia ya. WHO tahun 2019 menyatakan bahwa kanker serviks itu incidence rate-nya itu masih sangat tinggi. 527.000 kasus baru ya dalam 1 tahun, dengan angka kematian itu lebih dari 50%-nya, yaitu 267.500. Dan di Indonesia sendiri ini laporan dari WHO menyatakan dalam 1 tahun itu ada 36.000 kasus baru. Beda dengan Thailand tadi ya. Thailand tadi hanya 8.000 kasus dengan angka kematian 21.000 kasus. Jadi ini merupakan hal yang sangat mengkhawatirkan buat kita sendiri. Bahkan perkiraan kalau kita tidak menangani kanker serviks ini secara baik, maka di tahun 2030 itu bakal ada kematian akibat kanker serviks ini sebanyak 12 juta kematian. Dan ini terus terang akan menurunkan kualitas hidup wanita Indonesia. Data terakhir dari WHO juga menyatakan bahwa Indonesia menempati urutan pertama se-Asia Tenggara ya, kanker serviks di mana setiap jamnya itu bisa 2 wanita Indonesia yang meninggal akibat kanker serviks ini ya. Kemudian setiap harinya bisa ada 100 kasus kanker serviks dengan kematian setiap harinya 57 wanita. Jadi kalau dalam sehari itu 24 jam, artinya dalam 1 jam ada 2 wanita Indonesia yang meninggal akibat kanker serviks ini. Jadi kita bicara dari jam 1 tadi sampai sekarang itu sudah ada 6 kematian ya. Jadi benar-benar ini sangat mengkhawatirkan. Dan juga kalau kita lihat dari rentang usia yang kena kanker serviks ini berada pada usia produktif ya, antara usia 35 sampai 60 tahun. Bayangkan jadi wanita-wanita Indonesia yang harusnya bisa bekerja, bisa membimbing anak-anaknya ya, ini akan terganggu gara-gara dia menderita kanker serviks ini. Jadi kenyataan-kenyataan inilah yang menyentuh hati kita bahwa kita harus berusaha untuk menurunkan angka kejadian kanker serviks tersebut. Nah, WHO sebenarnya sudah punya resep atau strategi dalam rangka menurunkan kanker serviks ini ya. Jadi organisasi WHO dengan para ahlinya sudah bersepakat bahwa kanker serviks ini bisa kita berantas dengan optimisme di tahun 2030 itu sudah turun. Bahkan lebih dari tahun 2030 diharapkan kanker serviks ini lenyap di muka bumi. Ya, bayangkan ya. Sangat optimis sekali WHO untuk melenyapkan kanker serviks. Kenapa begitu optimis? Karena kanker serviks ini bisa dicegah. Ya. Penyebabnya 99,9% adalah infeksi virus HPV. Ya. Jadi seperti kita ketahui bahwa kalau ada penyakit yang disebabkan oleh infeksi virus, sebenarnya pengobatannya atau strategi pengobatannya adalah dengan melakukan vaksinasi. Ya. Vaksinasi. Kita punya pengalaman tahun sebelumnya kasus corona COVID-19 ya. Begitu kasusnya mewabah dan manajemen penanganannya cepat yaitu dengan vaksinasi, alhamdulillah saat ini kita sudah terbebas dari corona COVID-19 yang begitu mematikan ya. Demikian juga pada kanker serviks ini karena penyebabnya 99% adalah virus HPV, maka seharusnya dengan program vaksinasi terhadap wanita Indonesia, maka kasus ini akan bisa ditekan. Dan ini WHO merekomendasikan vaksinasi ini lebih diutamakan dilakukan pada usia anak sekolah. Dan alhamdulillah Kementerian Kesehatan sudah mencanangkan program ini dimulai tahun kemarin bahwa anak-anak usia sekolah mulai dari 9 sampai 15 tahun itu harus divaksinasi. Dengan harapan 10 tahun ke depan pada saat dia sudah menikah, dia sudah memiliki kekebalan terhadap infeksi virus HPV ini dan mencegah dia dari kanker serviks. Nah, perjalanan penyakit kanker serviks ini setelah wanita itu terekspos atau terinfeksi virus HPV, maka dia akan dilanjutkan dengan adanya lesi prakanker. Lesi prakanker ini